Men Only, a podcast for men, about men. What do men want to talk about? In this episode of Men Only, a marathon, not a sprint, we discuss the prostate cancer journey, from initial diagnosis, treatment and aftercare. Prostate cancer has overtaken breast cancer as the most common form of the disease in the UK. A record number of over 55,000 men were diagnosed in 2023, of which 12,000 will die of the disease. To gain a fuller understanding of prostate cancer, I will be joined by Professor Robert Jones, who is Professor of Clinical Cancer Research and Honorary Consultant Medical Oncologist at the Beatson, West of Scotland Cancer Centre. Joining him in the discussion from the Maggies Centre Men's Cancer Group will be Alan Keegan and Tony Burns, who will openly share their experiences of how prostate cancer has impacted on their lives. This podcast aims to inform men of the medical options after undergoing a PSA test and the decisions to consider when considering treatment and potential side effects. Hear directly about the physical and mental impact from men who have experienced the prostate cancer journey. Listen to what they have to say and what men want to talk about. I'm delighted to welcome here today Professor Robert Jones, who is Professor of Clinical Cancer Research and Honorary Consultant Medical Oncologist at the Beatson, West of Scotland Cancer Centre. Joining us today from Glasgow's Maggies Centre Men's Cancer Group is Tony Burns and Alan Keegan.
Hi there.
Gentlemen, welcome and thank you for coming along today to discuss prostate cancer. As you know, awareness of prostate cancer has been heightened, for example, by Sir Chris Hoy and the King. However, I've noticed recently a comment from Professor Hasim Ahmed from Imperial College, and he says the two biggest mistakes men make regarding prostate cancer are to, firstly, not think about it and ignore the whole debate, or secondly, jump straight into the PSA test before considering the pros and cons. I think we should be considering the pros and cons today with Professor Jones. Professor Jones, could you tell us about yourself and your work at the Beatson Cancer Centre?
Yes, so I'm primarily a doctor, but I'm also a researcher. So I'm actually employed by the University of Glasgow, but spend most of my time, nearly all of my time in the hospital. That's the Beatson Cancer Centre. The Beatson Cancer Centre is the largest cancer centre in Scotland and probably one of the largest in the UK. And we essentially deal in the drug treatment and radiotherapy treatment for pretty much all adult cancers. My personal clinical practice is largely in the treatment of prostate cancer, but I also treat bladder cancer as well. My research is essentially around clinical trials research, so that's developing new treatments. In my case, I'm principally interested in drugs, so it's in developing new treatments for the treatment of those diseases. And I also have a role coordinating the clinical trials that other people do at the Beatson as well.
Right, okay. I know there's been an awful lot discussed about prostate cancer, and particularly the first step being a PSA test. Men are encouraged to take this as a test, but could you explain what a prostate-specific antigen is and what the function is of the prostate?
So let's start off with the function of the prostate.
Yeah.
So most men don't know what the prostate is.
Exactly.
I've heard it described as
I certainly don't appreciate what it does. Yeah.
You don't really know what it is until it goes wrong.
Correct.
And I think the simplest way of describing it is that it's a gland. It's a gland that sits just at the base of the bladder where the tubes enter and leave the bladder. And its function is largely to produce the non-sperm parts of semen. Okay, so the sperm's produced in the testicles, and most of the rest of the fluids are produced in the prostate gland. So that's its main function.
So when they talk about PSA tests, what do you actually...
Yeah, so a PSA test, so PSA, as you say, it's prostate-specific antigen. It is a protein.
Right.
The body's primarily made up of proteins. It's a protein which is released by the normal prostate gland into the blood. So normally men have detectable PSA, whereas women will not. The key point here is that if you get, so normal prostate cells produce PSA, but nearly always when you get a cancer arising from the prostate, the cancer also produces PSA.
Right.
So what PSA, if you measure the concentration of PSA in the blood, it gives you a rough estimate of the total amount of prostate tissue in the body.
Right.
So if the PSA is higher than expected, that may be, not always, but it may be caused by the fact that there are an excessive amount of prostate tissue, and that excessive amount of prostate tissue may be there because it is cancerous.
Right. Say when men get, say, a PSA test which shows that they have evidence of cancer, is it normal that they're followed up by an MRI scan?
So, the commonest way that prostate cancer is diagnosed these days is by somebody goes to the doctor for whatever reason and has a PSA test and it's abnormally high. Right. And then normally under those circumstances, unless there's another obvious explanation for it, like infection or something like that, then normally the next step will be to do an MRI scan, because that can tell us whether the prostate looks abnormal or not.
Right.
That's a relatively recent development where the next step would be an MRI scan. It's only in the last few years that's been the pathway.
Yeah. So see, when you're talking about MRI, what does it actually do?
So an MRI scan is just another form of, I mean, it's not an X-ray, but it's essentially like a CT scan, but it uses a different technology. It doesn't use X-rays, it actually uses magnetic fields.
Right.
So it's just a way of being able to reconstruct images as though we have sliced through the body, and you can MRI scan any part of the body, and so what it does is it gives you a detailed picture of the structures, the normal and abnormal structures, in this case in the pelvis and around the prostate gland.
See, at what point do you consider doing a biopsy then?
So these days, if you've had a raised PSA and then you've had an MRI scan, the MRI scan won't give you an absolute answer, but it will give you, it may give you a strong suspicion that that there is an abnormality that is cancerous.
Okay.
And in that circumstance, you use something called a PIRAD score, basically. So the MRI scan may come back saying there's nothing of concern here, or it may come back saying that there's a lesion, which is sometimes it comes back saying there's very obviously a cancer here. More typically, it will come back and say there's an abnormality and we're concerned it might be cancer. So then the next step after that usually is to do a biopsy to find out.
Many men don't have symptoms, but they may present with symptoms that are not actually caused by the cancer, like frequent urination during the night. What age should men consider being tested, and what, if any, symptoms should they be looking out for? So
there's no absolute rules,
right.
And that's partly because there's not, there's no total clear evidence about it. But the current advice that Prostate Cancer UK issue is that men over the age of 50 may want to think about asking for the test, and in some men that may be over the age of 45, particularly if you've got a strong family history or if you're of African descent, because we know those people have a higher risk than average.
Right, Tony, and I'll like to bring you into the conversation. Can I ask you both how you both found out you had prostate cancer? Alan, do you want to? Or Tony, which one wants to go first?
The old one will go first.
I found out by pure chance.
Right.
I wouldn't say luck, because it's not really luck, but pure chance. I've suffered from high blood pressure for many, many years, probably working in the construction industry as a manager, and I've been taking tablets, and every 2 years you get checked. And my check 3 years ago, they do the blood pressure check, diet, etc., and they also take bloods. And it came back that my PSA was 28. I had no idea what a PSA was, and I asked the doctor, well, what should it be at my age? I was 61 at the time, and he said it should be around about 5. And I went, well, it's not a case, it might be prostate cancer. No, we don't know. Now, he never mentioned anything about the MRI. He said I was getting a biopsy. Now, I did get an MRI, but there was no talk about, well, this is told as this or this is. It just seemed to be part of the process. And then I had the biopsy, and it was confirmed that I had prostate cancer. And I was given the opportunity to either have my prostate removed or go through radiotherapy and hormone treatment.
Right.
I didn't know. I was asked what choice would I make, which I felt was maybe a bit unfair because I'm a builder, I'm not a doctor. But one of the reasons I probably asked him what would he do in my position. He suggested the operation. But one of the reasons was the operation was instant. You know, you were in and out in 3-4 days, whereas hormone treatment, radiotherapy could take a year to 2 years. Plus, if you go for the hormone treatment, radiotherapy, you can't have the operation. So I was giving myself options in a way. So I went for the operation June 2023. 22, sorry, it's gone up for 3 years. It worked at first test, it came back fine. The operation itself was simple, in and out in 2 days. I could have got out the day after, but I chose to stay another day. I mean, and you wear a colostomy bag for a week, which is a bit uncomfortable, and then you need to deal with the incontinence, which at the start is very, very heavy. But you get over that, you know, and then first test came back, it was undetectable. Second test came back, my PSA went back up to 0.1, still said that's okay. Third test came back and it was up to 0.2. And what I was told was, look, we can monitor you, but we haven't got it all as regards to the cancer, and it may come back or manifest itself. So they suggested 2 months or 7 weeks of radiotherapy. No hormone treatment because the side effects, I'd already started going to Maggies Centre to the men's group, and the side effects of hormone even now scare me. I've not had, other than the normal side effects like the incontinence, I've not had any physical, you know, hot sweats or putting on weight or anything like side effects, and all that scares me a bit. So
welcome to my world.
Aye, so that's the thing. After the radiotherapy, I've had 2 tests since then, and both have come back undetectable, my nicks. So it would appear, I've always got in the back of my mind, no, I was told after the operation everything was okay, but it wasn't. So I've always got in the back of my mind, I've just been lucky. Maybe the next test will come back and say, oh, by the way, we need to try something else. So that's really how my position.
Right. Over to the young.
I'm very similar to Tony. I had which I've still got, a groin pain.
Yeah.
And, you know, obviously, again, it was persistent. And I'm not a big GP fan. You know, I get a bit kind of fed up with them. So I went to the GP. She said, you know, unfortunately, all my GPs are all female. And that sounds very sexist, but they just didn't get it.
Yeah, okay.
So I had this pain. It was equivalent to someone hitting me in the testicles. And it was really, really painful.
Right.
Otherwise, I probably wouldn't have persisted with it.
Of course.
So went to my GP. She gave me antibiotics, told me that they probably didn't work, so gave me stronger antibiotics. And I thought, and at that point I was just about to say, you know what, I'm not going back. But I did. So whether it's an inner sense, I don't know. Went back and she said, you know, I'd like to do your bloods just to see if there's any underlying infection that we've missed. I got a phone call from her within a week, which was dead unusual. And she told me, you know, her opening words were, I don't want you to worry about this. But your PSA, and at that point, PSA, and I'm just thinking, I don't know what you're talking about. Because PSA didn't ring a bell.
Right.
I didn't even think about prostate cancer at that point. So all she said was, I'm going to make an urgent referral to urology. So I just thought it was something to do with, you know, the waterworks, I've got an infection. And then 2 days later, I got a phone call asking me if I was, you know, I could go for an appointment. It was almost like somebody had, you know, cancelled their appointment for an MRI scan.
Right.
And their wording was, before you go to urology, it's probably better so that they know what they're dealing with. And I was like, yeah, that sounds okay. So I went for an MRI scan, and basically they came up and said that it showed up. Didn't tell me anything, just there's something showing up.
Right.
So we're going to try and arrange for a biopsy.
Sure.
And again, I was still quite naive to it. I didn't think about prostate cancer. At that point, I'd heard about prostate cancer, but didn't actually know where the prostate was.
Right.
You know, and knew
just
nothing about it.
Just get back to the original.
Aye.
Yeah.
So went to the Royal Infirmary. It was just round about after COVID time, at the end of COVID. Right. So my wife had accompanied me, but she wasn't allowed in. So the usual, they take your blood pressure, give you an antibiotic because they're going to do a biopsy. And then halfway through the biopsy, I can always, this is how I found out I thought I had cancer. I can't even remember her name.
Blocked it out.
She basically says, that's cancer. She says, I've done thousands of these, she says, and that's cancer. What? Don't take my word for it, she said. Just wait, until you get, and I'm sitting there thinking, and then she says to me, just going to get your blood pressure taken again.
You'll be fine.
And I'm sitting there like, and all I could think about was, did I hear her right? Surely no. So, and all I could worry, I was so worried about my blood pressure because I thought they're going to try and keep me in tonight.
Yeah.
So that was basically how I found out I had prostate cancer.
So see, when I came to meet with the whole group at Maggies Centre, it seemed to be prevalent. There was an issue with medical language and understanding exactly what was going on. Now, Rob, I know that you're quite keen in the sort of like to talk about the doctor-patient relationship. Do you want to sort of expand on that?
Yes. So I think to sort of reflect a little bit, I think when things go wrong in healthcare, often it's a communication issue that starts it. I'm not saying that's to blame in everything, but if we communicate well with one another, but also between doctors and patients, then we'll almost certainly get to a better place.
Sure.
That's the first thing I'd say. Second thing I'd say is that for a patient and to do well with a given doctor, there's got to be trust there. And trust is based on being able to understand one another, and it's about honesty, basically. So those are just, that's just about life. That's not about being a doctor or being a patient. But we sometimes lose sight of all of that. So those are important things. I think also, Tony Allen, yes, Tony. You sort of raised the issue that you were given a choice. And the truth is that most times, particularly in cancer treatment, there's nearly always a choice, even if the alternative is actually to do nothing at all, because that's always a patient's right to do that. My job as a doctor is to present choices. I tend to work in patients with more advanced forms of the disease, and I'm delighted to see that neither of you two have, and hope you never do need my services. And we're often dealing with relatively nuanced choices of treatments. And also stacked up against that choice of maybe not having the treatment. And having that discussion with the patient, once you've got that trust and belief in one another, it's how we present choice to a patient. There's no point in like you said, Tony, you're given the choice, but actually, if you just give me options on a piece of paper, how do I know how to choose that? Okay. So it's about choice, but also guidance within that choice. Yeah. You don't want a doctor who says, these are your options and sits on the fence. I don't think. Sometimes it's genuinely, really, I don't think there's anything to choose between these options, in which case, I would just go with A or B, A rather than B. But how is how we help patients make the right decisions for them, and in order to do that, I think as a doctor, I've also got to understand a little bit about as much as I can about the patient, and part of the way I work is that I'm often working in the very long term with patients over sometimes many years. It's actually, I think it's really important that I get to know the patient so that I can understand a little bit about what so I've got an angle on what I know is important to them as well.
What do you think, guys?
I think the problem with it is, from the incontinence point of view,
right?
I thought that was a breeze, when they were talking about it. So when I opted for surgery because, again, like Tony, I had the same options.
Yep.
And I chose the same as Tony because I thought that gives me a plan B should plan A not work. When they mentioned certain things like incontinence, sexual dysfunction, I thought, but they tell you that it's going to get better, but they don't tell you that it might not.
Yeah.
So I really struggled with incontinence.
And you felt that you hadn't been warned sufficiently about that.
I think that they make it
risk,
sound as though this will be an initial thing, but it will get better.
Yeah.
And mine's has fluctuated even now, then I'm 2 years down the line. So, and it just, excuse the French, but it pisses me right off.
Yeah,
because
literally.
I think the other thing as well, I mean, I was diagnosed during COVID, so I went in myself. Since then, I've always had someone with me. But you sit down and you're told, oh, you've got prostate cancer. This is what we can do. Now, all I've heard, I mean, I'm 65. When I was young, woman next door had cancer. 6 months later, you were burying them, you know. But things have all I've got in my head is cancer, you know. And this consultant is putting proposals to me, and my head's away in another world, you know. I think, oh, geez, I'm only 62. I'm not, you know. And I think that is, but I also think that the side, you know, because you're wait, what's the side effects? Incontinence. Now, I still have it, but I deal with it, you know. And erectile dysfunction, now they say it's a certain percentage, but we will have, 20? No, not everyone there has got prostate
Should we just
cancer.
explain exactly what we mean by erectile dysfunction? Because we all know what that is.
Yeah, well, I mean, it's probably, I mean, put it this way, I'm not in a relationship, but if I was in a relationship for the past 3 years, there would be no sex. If
you can't get erections.
You can't get erection. You just can't get one.
Just to be honest, to be open and clear about it. Yeah.
You can't get an erection. And you're told it affects 1 in 10 or whatever, you know. But not everyone at our group has got prostate cancer, but everyone there who has, and everyone I know, all suffer from it.
Right.
So it's a 100% chance that you're going to get it. Yeah. Now, I'm not in a relationship, so it doesn't affect me. But to be honest, it's your manhood in many ways, you know. But the other thing that's really is, in 3 years since I've had my operation, I have not had a full night's sleep. I'm up 2-3 times a night to go to the toilet. Now, I'm not wet in the bed. At first I was doing that, but it's just, you know, and even if I stop drinking at 6 o'clock at night, I'm still up 2 or 3 times a night. And that's for 3 years. You know, and I've accepted that will happen ad infinitum.
Rob, is there anything that you can do for that, like pelvic floor exercises?
Yeah, but I've been doing them. I do them, and it still doesn't work.
Still doesn't
No
work?
for the incontinence, no.
No, nothing?
No.
That's not really I'll be honest, it's not really my area of expertise. I mean, yes, there are things that can be done, but I guess it's a matter of making. Often it's a matter of making the best and finding ways of living with it.
Well, I've accepted. I mean, I'm still have to wear pads, you know, and I've accepted the fact that I'm better with it now. You know, because the turning point for me was I didn't know about Maggies.
Right.
So my turning point was I went to Maggies.
Yeah, and you met other women.
Tony was the first person, my point of contact when I went to Maggies.
Never mind,
never mind, I know. So we all have our crosses to bear. But I think the thing is, I listen to other people saying, well, yeah, but it's not, it's like it's an illness you've got. So, and people just need to realise that it's not as though you're just sitting there urinating yourself. So I kind of came away thinking, do you know what? Yeah, you're right. And I don't know if that was just a turning point where I just accepted the fact that, okay, it'll get better and there'll be days where it's worse.
Yeah.
But I've got to accept it because that's just the way it's going to be.
Right. Going back to see that, I'd like to think about the original meetings that you have with an oncologist. Do you think you were prepared for that, or do you think it's always better to have someone there? Well, you were on your own. I think that must have been very difficult.
You definitely need to have someone with you.
Because do you actually take in what the oncologist is saying to you?
You only take in some, you don't take in.
And that's a very difficult thing.
For instance, I still don't know what my Gleason score is.
Right.
I was probably told it at the time, but I don't. The only thing I remember is them saying, you've got prostate cancer. And then they go into, well, this is your options. And my head went into overdrive. You know,
it's got to be the worst word. The cancer's got to be the worst word in the dictionary.
Absolutely.
Because, you know, the mind just goes into chaos.
Because I always sort of think it's like prepping for any meeting. If you've got your list of questions, and at least if you've got someone there who can prompt it, it's a reassurance as well. Do you want to explain the Gleason score for those out there?
Yeah. So when we're assessing a new case of prostate cancer, there are various. Not all prostate cancers are the same. okay, and they're not all treated in the same way. And so there are various bits of information that we use and enable to best map out the best treatment options for that patient. So fundamentally with prostate cancer, there are essentially three important factors. There's the Gleason score. So the Gleason score is what we find on the biopsy. Okay, so that's a description of what the cancer looks like under the microscope. It's a slightly complicated score because it composes two different Gleason grades. So you look at and very confusingly, the grade is 3, 4, or 5. There's no 1 or 2. And so you look at the commonest grade and you look at the second commonest grade and you add them up. So a Gleason score will often be described as 4 + 3 = 7, or 5 + 3 = 8, or whatever. Fundamentally, so the lowest score you can have is 3 + 3 = 6. Right. The highest you can have is 5 + 5 = 10. 6 is the least aggressive. 10 is the most aggressive. So that's the Gleason score. The second factor that we look at is the PSA. So how high was the PSA at the time of initial diagnosis? Is it? So fundamentally, for this purpose, we categorize it. Is it less than 10? Is it between 10 and 20? Or is it more than 20? And the third thing we look at is what's called the stage. So that's often described in 1, 2, 3, or 4. But here, more typically, we're looking at it with a little bit more granularity. So we look at something we use a system called the TNM scoring system. So T stands for tumor. And that's a measure of how far the cancer has grown within the prostate. So a T1 is one that's only seen on the biopsy. A T2 is one that you can see on the scan, but it's not reaching what's called the capsule, the lining of the prostate. And T3 is one that has reached to the capsule of the prostate. And T4 is when it's actually started invading into other structures beyond. The N is nodes, so that's lymph nodes, and that's something we would see on the MRI. So the T stage is typically something we would establish on the MRI scan. And similarly, the lymph, so node, N stands for nodes, that's the lymph nodes. We have lymph nodes all over our body. And often when a cancer spreads, the first place it spreads to is the lymph nodes. So we're it'll be the lymph nodes close by the organ where the cancer is. So in prostate cancer, we're looking very specifically at the lymph nodes in the pelvis. These are sometimes called lymph glands. They're the same thing. So the lymph nodes in the pelvis, and that's something we would look at on the MRI scan. And the M of TNM stands for metastasis. And a metastasis is that if it's spread to other parts of the body. And that's usually something which would be established on a bone scan and sometimes a CT scan. And increasingly now we're also using PET scans. You probably had a PET scan.
Yeah, I've had both bone scan and PET scan.
So that's slightly limited the situations where we use PET scans still.
Right. Can we go back to just discuss and say that it's a very low reading of PSA, and there's a technique called active surveillance. We discussed that in the Maggies Centre. Could you just explain what active surveillance is, Rob?
Yeah. Well, we need a little bit of background to this first of all. So PSA's not a perfect test by a long stretch if you're looking to diagnose cancer. Okay, it has lots of uses, but obviously here we're really talking about the ability of PSA as essentially like a screening test, if you like. And it's not a very good screening test, is the truth of the matter. Right now, it's probably still the best that we've got, the best that we can practically implement. And the reason it's not a very good test is for three reasons, really. The first is that you can have a normal PSA and still have prostate cancer. So in other words, it won't find that one. You can have a high PSA and not have prostate cancer. So that patient ends up going through tests they don't need. And the third thing is, of course, that even when you do detect, even when you do detect a prostate cancer, not all prostate cancers are what we call clinically significant. Okay, now, so if you say, well, how can you have a cancer that's not clinically significant? So clinically, it's not medically significant. How can you have that? So the definition of that really is a cancer which never causes that person, without treatment, never causes that person any more bother in the rest of their natural lifespan. Okay, now we don't know that until you've died of something else. So it's not a very helpful definition. But we do know that the harder you look for prostate cancer, the more you will find. But of course, you will find a lot of cancers which are never going to cause any further trouble during the remainder of that man's natural life expectancy. Right. The problem is we don't know we don't know which ones they are. Okay, right. So when we're looking at these scoring systems, if you have a very low risk cancer, so it would be a Gleason 6 cancer with a PSA of less than 10, one that hasn't spread towards the capsule, so T1 or T2, we know those patients are generally, and this is the catch, is it's generally at very low risk of the cancer ever spreading anywhere else. And of course, it's that spreading which actually causes the trouble. Right. And so actually, it's important that we don't put those men through treatments like surgery with all the consequences that you talked about, when in fact they never needed it in the first place. So active surveillance is a way of trying to allow patients to continue without treatment, but whilst keeping a close enough eye so that we can, that if we've got it wrong, if you like, we've predicted wrong, and in fact it does start to behave more aggressively, we can still catch it and still operate or do radiotherapy. Okay.
What's the regularity of tests or checkups when you're doing active surveillance?
So that varies a bit. According to the sort of the baseline characteristics, if you like, and again, it's not my area of expertise, but fundamentally, it consists of monitoring the PSA, keeping an eye on the PSA. But often now you'll also repeat the MRI scan, usually about a year later, and sometimes after that as well.
Tony, you always mentioned that you've always got cancer. You're always thinking about that. When we discussed that in the Maggies Centre, we talked about active surveillance. What generally did what were their concerns about that? Was it a case of like you could get, say, a test, a monitoring test, but it might be the next day that suddenly it starts to develop? Is it the timescales that you were worried about? Would you have considered active surveillance if it had been an option?
Personally, I just wanted rid of it.
Right.
That was my take.
Were you offered active surveillance even? So probably your tumour was not one where the doctors would have been comfortable offering that anyway.
So I didn't get it. I got either surgery or radiotherapy, stroke, hormone treatment.
So we wouldn't offer active surveillance to all patients. It's only patients. Generally speaking, those Gleason 6 tumours.
Well, I was told if this room is my prostate, the cancer's at the door.
Yeah.
I hadn't got through the door yet, but it was at the door. And I was also told, you'll not die of it, you'll die with it. You know. But I mean, the getting away from the prostate thing, I now believe that I have cancer. Right. It's maybe gone from the prostate. I must have been born with it because you can't catch it. We've had this discussion before. You know, and in your head, and the fact that I was told I was okay after the operation, then I was told, oh, no, you're not. Yeah. I've got in my head that, well, what is inaccurate? You know, you never get told it's gone, you get told it's undetectable, which means it must be there somewhere in my head. I mean, I'm a 3/4 empty guy, I'm not even a half full. Again, probably my building background, but my issue, the testing's fine, you know, I mean, every 6 months is fine. And the one thing I'll say about the NHS get hard, the way they treated me and how they've treated me both times has been very quick and and I've got no issues at all. GP's another story, but we'll not go into that tonight. But as regards, you know, March I was told, June I was operated on, then the following September I was told it hadn't worked, and then I was getting treatment January, February. So I've got no issues with the treatment, but I've got in the back of my head that I now have cancer, right? And it's going to, not have, I was born with it, right? That's how I deal with it. Because touching him, I don't give him it. And I think, I mean, I've got friends who, they had one friend in particular, lost a leg at 10 through cancer. He's 66 and he's gone through chemotherapy just to extend his life by 6 months. So you think, you know, I'm maybe thinking worst case scenario, but that's certainly how I think. But I think the testing is fine. The issue is, coming up to the test, you go and get your bloods taken, then you wait a week for the test results, and that week's, for me anyway, it's absolute murder, because you don't know, you know, you're going in there expecting me to, it's not worked again, Tony, we need to do B, you know, whereas you go in, you go, the relief is incredible. It's
the same with everyone in the group. You know,
there is always that anxiety before you get the blood test.
Because there's always the unknown, you know, and it's almost like it's almost like a cheer when somebody comes and says it's undetectable. Yeah. Purely because everyone knows what you're going through.
Yeah,
you know,
of course. See with the Maggies Centre, obviously we've talked about the physical aspects of it, but there's also sort of the mental aspect where you guys can very open. And what struck me about speaking to you was it wasn't a case of it was all weeping and wailing. You were all very upbeat. And I think it was the fact you could all speak to one another about it quite openly, because I was when I went into the meeting, I thought, right, there's things I want to talk to these guys about, and erectile dysfunction was the top of my list. I thought, how on earth am I going to bring that into the conversation? And then you just immediately brought it up. And I'm thinking, that's great. You were so honest and open about it.
Because you get a leaflet. That's there's your information. There's a leaflet. Yeah. And again, it tells you that you may. Mm-hmm. So,
but was it much more reassuring speaking to other men?
I think more
informative.
Yeah. So you think you're unique in many ways. Yeah. Some of the things that happen, and you go to the centre, and what you're speaking to guys. With all due respect to family and friends, okay, family's different because it affects them, but friends they do their best to reassure you, console, whatever you want to call it. But you walk into that centre, we've all got different backgrounds. You walk in there, and if I say something, everybody in there gets it. And if somebody else says something, everybody in there gets it. Alan came in, I was chatting to Alan, and Alan was, I get it. And that's the thing, you're not unique. You think you're unique, but you go to somewhere. I mean, the centre's been tremendous for me. I wouldn't be as confident to speak about it as they're not going to. The centre does a tremendous job, not just for prostate cancer, for all cancers, but the men's group. I mean, I thought when I was told about it, you go and you say, "Hi, my name's Tony, I've got prostate cancer." It's nothing. It's up, as you know. I mean, it's off your team. Your team gets stuffed at the weekend and it's general chat, and somebody will maybe bring something up, or you'll come along, and then we all take part.
Because I've visited the Maggies Centre many times, and I always know when the men's group's there, I can hear you chatting at the end of the road.
Of course it is,
and it's just like, there's a vibrancy about it, and I'm thinking, what are they talking about? Right. Now I know.
I think it's about, there's no sympathy. You're not going there looking. You don't go there looking. Yeah. I think sometimes you're a bit down, and sometimes if somebody gives you sympathy, then you just wallow in it. Aye. Whereas there you don't get it. So the bottom line is, if you've got an issue, I could never speak about sexual dysfunction. I thought that was like, because that's who I am.
It's definitely.
That's part of my identity. And I was kind of assured that because I didn't have any issues with sexual dysfunction prior to surgery, then I stood a good chance that it would come back normally. And they gave me kind of a 2-year, the leaflets give you a 2-year time scale. Right. And I literally counted it down.
Right.
And after 2 years, I was like,
right,
this is
come on,
this is the day, and nothing, and it's and it's the strangest thing because you set yourself up thinking, it's 2 years to go, 1 year to go, and basically you're thinking you're going to have this erection, and it does, and nothing, and that I was, they can ever tell you that, if you get surgery, you shouldn't get these types of symptoms. I probably get more symptoms now of prostate cancer than I had previously. So I've got the sexual dysfunction, I'm up during the night for, that urinating. Yeah. And I never had these before, but I feel really lethargic all the time. Yeah. And they're thinking, but that shouldn't have happened to you because you haven't gone through the radiotherapy type, and the hormone. And I'm thinking, well, I feel it. Is it just me? I don't know if it's just me getting old, but I feel it. But so I used to have this get up, and sometimes I'm just thinking, I'm done.
Because I know you're a taxi, a driving instructor, and you were sort of saying that it's affected your work life as well, where you're having to sort of like plan when you see your clients.
Yeah, you've got to have a bigger break, and the first thing you do is have a recce where all the toilets are.
Where the toilets are,
right? You do, you're like, as soon as you go somewhere, there's a toilet.
Yeah. Just pull up here on the left.
Because that's the thing, you can't be caught as quick as that's why the same as I'll go in a new place and go, right, toilets are over there. Right. And that's your first. Because you don't say, this is a lovely place, there's a toilet.
Because you used to be able to hold your toilet in, like I can hold that in. See now, it's just, if you need to go.
You need to go.
It's just, there's no holding it back.
I don't know whether it was you that said it, Alan, but or was it you, Tony? There was somebody in the group that talked about a sense of isolation sometimes because it affected you being able to go out and socialise and see family and friends. So it's all the sort of social aspects as well, which is obviously impacting on you.
I mean, as I say, I'm single, divorced, but if I was to meet somebody, I would need to be upfront with them. You know, not that I'm going to meet anybody, but you know, I'd
never give up hope.
I would need to be upfront, and even if how a married man can cope with it, I don't know, because if I was still married, I would need to sleep in a separate bed because I'm up so much during the night because it wouldn't be fair to my partner. But also when I'm on my own, and it's amazing how sometimes on your own you all of a sudden feel sorry for yourself, you know, and you the number of times you think, why me? You know, I mean, the year before I was diagnosed with epilepsy, never had anything, so I had to stop working. And then the prostate, you think, what have I done? Why me? You know, but if you socialise, you need to be very aware of, and before you know it, you're going to the toilet every 5-10 minutes. You know, and like, I've booked a holiday, I've booked an outside seat near the toilet. Purely because I know I don't want to be getting in and out of other folk. Excuse me, you know, and that's how you've got to think, because that's the thing you need. And like Alan, I wear a pad all the time. Even at night in my bed, I double up my pads just in case I don't, you know, my brain doesn't kick in and say you need to get to the toilet. And these are the things that but when you talk to the guys at the centre, they're all there. I've been there. I mean, probably if you did a head count, 90% of the guys probably wear pads all the time.
Because I remember one of the guys also said he'd sort of adapted to this was his new reality, and he sort of didn't accept it, but he just knew that was where he was at the moment.
I went to my GP because I was really, really down, and they said, but this is the new norm for you. You just need to adjust. And I thought, and how do I do that? You know, this is not what I signed up for. You know, and with regards to the sexual dysfunction, because they gave me all the different types of Viagra. And I got to a point where I actually started mixing them just to see if I could get some sort of kick at it. You know, nothing happened. And I thought I would be okay. Me and my wife discussed it. I've been married a long time, and we thought, look, you know, my wife said, all I want you still to be here. So I want you to get the surgery, otherwise. And I thought, right, okay, we can deal with that. But to lose the intimacy is really, really tough. It's tougher than I thought, you know, so... and we try to be intimate, you know, but there's something missing now that was there before. And I think if you're a little bit kind of like uncertain in your relationship, you know, that would be tough, because you're always thinking that if my wife wants to still be sexually active, I can't give her what she wants. So...
I don't know. I think sometimes, you know,
tough.
If you've got a partner or a husband or whatever who's that seriously ill, I think it's what your wife said. You really just want them to be there. That's it. And I think what it does, cancer does to the person and to the family and the friends, it strips away everything that's extraneous in your life, and you realise what really is important is that person. And I think it is you adapt, because you'd much rather have them be beside you, being able to talk to them, than them not being there. So I think the choices are stark. But at the end of the day, I think your wife probably just wants you.
Of course. But I think guys sometimes, again, especially as you get older, there's an insecurity comes with that.
Of course.
You know, your libido is, you know,
because it's very intrinsic to being a man.
You know, you always like to think that you've still got it.
You know, guys, you've still got it. Come on.
You know, and it's just.
But, I mean, well, you touched on one thing there, because I think, you know, actually it's great to have an open conversation about erectile dysfunction. But you mentioned libido, because I think that's something which often men find even more distressing than the loss of the apparatus, if you like. It's the loss of the desire and the drive, and that's particularly an issue. And I know it doesn't affect you two guys, but when we're using the hormonal treatments, that can be a really big issue, because it switches off the libido as well.
Because I thought because I get surgery, then that wouldn't be the case. And there's nothing. Nothing. There's not even a desire. There's nothing.
No, there's absolutely
and that's the strangest part of it. You know what I mean? It's I don't know how to explain that part. You know, you just think that even it's a bit like if you had seen some sexy lady in front of you, you'd be like, just move over a bit. You know?
I want to watch the football.
Aye. So, and that's strange to, you know, because you're always thinking, and I was sexually active right up to I got surgery, and I had this idea in my head that, well, you know, if I'm sexually active right up to then it'll be okay because it'll come back.
Right.
And I was devastated when I still have these sensations, and then I'm like, no, it's nothing.
No,
it's a blame playing. The mind's playing tricks with you, you know. So
I think folk don't realise, as touched on earlier, Rob, is what exactly a prostate does. You know, given its size. I mean, when I tell friends that you know when it gets taken away, what goes with it, they're gobsmacked. I said in the cell, I says, even if I did get an erectile, there's no sperm. You know, there's nothing. And they go, I says, I'm telling you, if I think it's maybe that size, you've no idea.
It's about the size of a walnut.
Sorry?
Normal prostate is about the size of a walnut.
And I think that there's an ignorance of exactly what, I know that can't stop you having prostate cancer, but if men maybe realised exactly what its function is, but it's probably the main function in a man. You know, whereas, say, a woman for having a child, the main function for a man is the prostate. You know, but you don't realise that until you don't have it anymore.
Exactly.
You know, and it's incredible what it deals with incontinence, it deals with erections, it deals with sperm. You know, the whole action down there is controlled by this, as you say, walnut, basically.
And the mind is the toughest part. The mind is trying to keep your mind.
So how do you guys deal with it? Not just now, but how do you see yourself dealing with it as time goes on? Well,
it's funny what Tony says, because Tony says he's on his own, and there's days where he can be. But I'm married, and I can find days where I'm really down.
Right.
You know, and that's my issue. It's not my wife's issue. Yeah. So I still try to, you know, disguise it.
Right.
But there's days where I'm
Is
really,
that where Maggies really steps in, where you can go to that group and you can just have that honest discussion?
Aye, because again, there's people there as well. I've had a few times where I broke down in Maggies because
just
can't cope with this. I can't deal. So that's the lifeline that, and I never even knew it existed.
Right.
It was my wife that found out about it.
Oh, was it?
Aye. Yeah. And she says, you know, and I was never a group person. I was never like, let's go to a group. Because I thought, like Tony again, I don't really want to be the centre of attention. And I thought, you know, it's like master, put you in the middle of and everybody will kind of question you.
Yeah.
But, you know, so I went along and I kind of stood about and didn't really know what I was doing, or I didn't actually know why I was there.
Right.
I just knew that I had to do something. And I was lucky because I met Tony. There's a few guys in there that if you meet, you wouldn't go back.
It's okay, I'm going to edit that bit
out. They know who they are. So I was quite fortunate. I met Tony, who we're kind of on the same. Because again, he's on a journey and I'm behind him.
Yeah.
So what he was going through, I thought, well, if he's managing it, then I can see a light at the end of the tunnel. You know, so, and I think that's what
you've just got to deal with it. I mean, you've no choice. You know, I mean, I'm on antidepressants, right? But I still have down days, and that's the thing. You phone your doctor. I mean, I was diagnosed 3 years ago, and I've not had a face-to-face with my doctor in 3 years. Everything's been over the phone. I tell him what's wrong with me, and he prescribes something for me. The best thing that happened for doctors was COVID, GPs that is, because then they don't need to see you in the surgery. But anyway, I'm not getting on to the political side of things. But I'm sorry, I hope I haven't upset you. You know, so you just have to deal. What's the alternative? You can't change it.
Yeah.
You just deal with it, you know. And I remember when I was getting the radiotherapy, I was first thing in the morning, and I'd be sitting down at the Beatsons, and we're wheeling folk in beds and wheelchairs, and you know, and I thought, I'm actually not as bad as them, but you can only deal with what you're given.
Absolutely.
You know, I mean, when I first got diagnosed, I text, he's not my best friend, but he's my oldest friend. His immediate came back, if you're going to have a cancer, wee man, that's the one to have. That was his first response.
Is that not just a reflection of the fact that there is that ignorance out there about what
totally. If you're going to have a cancer, if you're a male and you're going to have a cancer, that's where the ignorance about it comes in. Because having that cancer, it might be the safest, as in but it also probably has the most
impact
on your manhood, for want of a better expression. But that's what he came back with. He was, oh, if you're going to have a cancer, wee man, that's the one to have. You know, and it's this ignorance that you know, I want to get prostate cancer and they think.
I think it's because do you think it's quite glib? There's a lot of advertising about prostate cancer, and it's just like 1 in 8, and they give the stats and going along and have this PSA test, but it's really, that's just the start of a long journey.
Definitely.
And I don't think that's made apparent.
Yeah, do you want to, because you started off quoting Hash Ahmed, and that was one of the things that he said is the two things: one, not thinking about it, and two, then asking for the test without thinking about the implications of that. Because I think that's a really important point. I mean, both of you guys presented in a slightly different way, but of course, you know, there is, particularly since the Chris Hoy publicity, you know, there's been a lot of talk and a lot of impetus about men going, you know, asymptomatic, healthy men going and asking for PSA tests. And I'm not sure that, you know, every man can ask for it over 50, but it's not necessarily the right thing to do for everybody, okay? And I'm not going to sit here and say you should or you shouldn't do it, actually, because it's very much a personal decision. And I think you do need to think a little, you do need to at least think a bit about whether it's the right thing for you.
Because it's terrifying, isn't it? You know, it's terrifying because, again, it's okay saying I'll go for the test. But then, what if what if it comes back and it's not the result you wanted?
Well, So and the other thing is, I would say, is that, you know, I said earlier that one of the PSA is not a very good test, and one of the reasons it's not a very good test is because it won't detect all cancers, it won't be abnormal. So if actually your only reason for wanting the test done is for the reassurance that you don't have cancer, it's actually not a very good test for that at all. So it's only really there to increase the proportion of patients where we detect prostate cancer earlier, and that can come, you know, and then setting off a chain of events, really.
I think Chris Hoy is a perfect example, because most folk, I think, even I did, it's old men that get prostate cancer. You know, you maybe you turn 60, 65, and you start going to the toilet maybe twice a night, and you put it down to old age. Right, it's my age. And the fact that somebody is fit as Chris Hoy. Now, okay, King Charles, he had some form of prostate cancer.
He's a much older man.
He was an older man. He was 70 or whatever, and you think, well, he's getting the best treatment. But there's Chris Hoy. You don't get anybody fitter than Chris Hoy. And he walked out, I don't know, 2 weeks ago at the rugby, and he walked out with the rugby ball in his hand, and the guys, I mean, we're fortunate. Ours was caught, his wasn't, and you think, if he can catch it at his age, or be diagnosed with it, then anybody can. And you know, and I wouldn't be surprised. I mean, after I was diagnosed, all my friends at my age, first thing they did was go to their doctor and ask for a test, but purely on the back of me, because they saw me and they thought, nothing wrong with Tony, he's looking great.
Yeah, I mean, I think picking up what Rob was saying as well about Professor Ahmed, he also said, it was an article in the Times, and they did, I think I'm right in saying they did some research to in relation to active surveillance and to those men that had treatment, and I think the results, I could be wrong, Rob, you correct me, was that there was very little difference. You know, and it goes back to
what... So this refers to a big trial called Protect, which was actually, we must understand that trial was actually conducted many years ago now, because we've actually got 15 years of follow-up. Sure. And that was a trial where it was a screening trial, so they essentially randomly approached men for PSA testing, and when they were diagnosed with prostate, so it wasn't men that went to the doctor with a problem, who were invited to take part, and when they were diagnosed with prostate cancer, they were then invited to be randomized into a clinical trial where they were randomly assigned to either prostatectomy surgery or radiotherapy or active surveillance, which is this, as I say, this is this process by which you don't operate immediately, you wait and you watch. So these were all men with what was at the time considered low-risk prostate cancer. And as I say, you know, we have much more sophisticated MRI scans and things like that now, which so it's a slightly different group of patients from how we would currently characterise. And what they've shown is that with extended follow-up, that's actually So the first thing is that actually very few of those men had died of prostate cancer. Okay, in any of the 3 groups. That's important, and there was no difference in the 3 arms. Now, remember, active surveillance isn't not having surgery; it's waiting and watching and only doing the surgery or radiotherapy if the cancer shows signs of activity. And a significant proportion, I think it was about 40% of patients, did go on to get, in the active surveillance, did go on to get treatment. But despite that, there was no difference in the survival rates. There were some other differences. So there were slightly more men in the active surveillance group where it was subsequently found to have spread elsewhere. But interestingly, even that didn't translate through into those men having a higher chance of dying of prostate cancer.
There's also been a lot of articles about different drugs or different methods coming onto the market. What do you say, Rob, is the future of, testing for prostate cancer? Is there any new techniques or anything on? I know with new drugs it can take years. Is there anything that's maybe imminent that'll help?
So there are 2 parts to that question, really. So my area of expertise is obviously in that bit about new treatments, and here we're really talking about new treatments for men where it has already spread beyond the prostate gland, okay? And these are men where we believe we can't cure the disease, but where the aim of treatment is to try and control the disease, and that means allowing men to live as long as possible with as few symptoms and as few side effects from treatment as possible. So that's always a balancing act, and that's an area where we've made a lot of progress in recent years. As I say, we're not curing anybody in that situation. I don't believe, but we now have a lot of treatments which we know can significantly extend not just the amount of life those patients live, but also enable them to live more years with a higher quality of life without the symptoms of the disease. And that's, of course, that's balanced against drugs which have an acceptable side effect profile. Now, of course, and that's why I come back to these individualized decisions, because what's acceptable is different for some men than others.
Guys, have you got any questions that you'd like to ask Rob?
No, I think he's explained more than because we're always learning about it. So I'd learn more about the prostate. I'd done a course in the Maggies for cancer, or prostate cancer. And again, you learn again more about the function of the prostate.
Was that the course you did before I saw you? Because I got told I couldn't see you because you were all doing a course.
That's what it was, So, and it's informative because that's all it was, inform me, and then I can make better decisions on how I move forward now. So, and I think Tony's right, we can't do anything about it. So we've got to find a way that we can deal with it. And mentally, I think if you can deal with the mental side of it, then the physical side will take care. I can't do anything about the physical side. I can ask professionals if they can help me with the physical side. So if I keep my mental side doing okay, then that prepares me for the physical side. And that's the way I get through it. So
I think there should be. I mean, the way I look at it, I went in and was told in a 10-minute session with a consultant, you've got prostate cancer, this is your... Now, the next person getting in, that consultant might be telling them you've got 6 weeks to live or something. So they need to be a bit neutral. I think the mental, maybe there should be something, and by you get you have the operation, you get a physiotherapist telling you about the exercises, diet, water consumption, etc. But you don't get someone saying, right, well, let's talk about dealing with it, mentally dealing with it. I think folk think, well, I'm okay, and away you go, and I think, and folk will say, oh, you're looking great, because I don't think they expect you to be looking like yourself, but up there your head's in scramble mode, and probably in and out for the rest. 3 years it's been up there in scramble mode. Not all the time, but some. So maybe if there was I don't know, a session's maybe not the word, but, somebody that you can talk to and say, by the way, this is how I'm feeling, talk about the lack of manhood, let's put it down to basics, or I'm having to pee every half an hour, that sort of thing, because that can affect you,
Of course.
Physically, it is what it is, you can't deal with that, but mentally you need to deal with it, you need to try and deal with everything else. I mean, I was fortunate, I had already retired from work, so I didn't have to go to my work and deal with my work and deal with that. At the same time, all I had to deal with was that. And then you've got your family, you've got to think, I've got a 32-year-old daughter. It took me 5 days to tell her where I was because I didn't know how to tell her. So maybe some sort of mental side, something like that.
See, there's no signposting, see if you were signposted to say, even with the Maggies Centre, here's a centre, you can go and speak to people. They have people to speak to. They have a psychologist there as well. They have the men's group. So whereas I was away beyond surgery, had made my decisions, and then I was struggling to live with them.
Yeah.
And that's when my wife seen how down I was about it. At one point, I didn't want to get out the house because the incontinence, even with pads, I was still, my advice at that point off someone was just wear dark clothes. And I'm thinking,
carry a bag.
So, but I was walking down up the street and I just thought everyone in the street must be staring at me because I was wet.
Because you're so self-aware.
And I'm like, I'm not going out. I'm not doing this, because again, what if I don't get to a toilet? What if they're, it's crazy stuff that goes through your head.
There's something else I remember what you said to me as well about people sort of coming up to saying, are you okay? And that's the last thing that you want to hear.
Of course it is.
See, when it comes to like family and friends, obviously when they know somebody's got cancer, I always think they fall into two camps. They either want to say, I'm really sorry, or they want to avoid you because they don't know what to say, not because they don't care, but because they're embarrassed or they're just not quite sure how to handle it. What would you say to people out there? Instead of saying, I'm really sorry that you've got cancer, what would you prefer them to say?
Nothing
at all. Just treat you the way you would normally.
You don't want to avoid it.
Yeah.
No, that's exactly
I want them to treat me as they would treat me if I didn't have. I've got a very close friend who I worked with him, so we worked together. And he's every night on his way home from work during my radiotherapy, he'd phone me, do you need anything? Do you want this? Do you want that? But he just treats me as a friend. When I was told we'd want to go to Berlin for you, when I told him that I'd been cleared, right, we're booking fucking Berlin tomorrow. Sorry for swearing. We're booking Berlin. Booking Berlin tomorrow. Right, and that was it, and away we went. And that's what you're looking for. You're looking for somebody.
You're not continuation of normality.
You're looking, just be you know. But you also need someone there that you can, when you're having it, like that's what the centre's great for. You go
fabulous.
there and you'll say, Alan, I'm not doing well, do you want to have a chat? Can I speak to you? But you want to be treated the way you're treated. You don't want folk feeling sorry for you. Because they don't get it. And that's no disrespect to them. They just don't get it.
That was very apparent in the men's group. It was that lack of sympathy. You were just there as guys speaking with one another, and obviously a lot of you knew each other very, very well. So it's like...
Well, I mean, I consider Tony to be a friend of mine, We message each other. If I don't turn up at, the centre, then there's always someone that will message you to see if everyone's okay.
That's great.
And that's what we do. We have our days out, and again, we have a day out because, we don't go out and speak about cancer. We go out and it's just it's almost like a worst day out or a worst night out. So.
Right, guys, I think that's been really informative. Is there anything else that you want, final words, because it is all about men, any final words that you'd like to say?
If there's anyone out there that has concerns, there's places to go.
Right.
And they need to just realise that it's not the end of the world.
Right.
It might appear to be the end of the world, but we're testament, you'll lose your identity, but you'll find another one.
Right. Excellent.
Yeah, I think also, especially pushing Maggies, there's guys in that group who have 15 years they've lived with prostate cancer, and that's a great, because you think, I've got 2 years at the most or whatever, 15 years and they're looking great, and I think that's the thing, as Alan says, it's not, when you first hear about it you think that's the end of the world, but it's not, and just be aware of yourself, don't take things, put it down to old age or put it down to this, be aware that you may have an issue and get yourself checked or whatever, or inquire. But I'd say probably be aware. Don't just assume that put it down to old age or put it down to something else, maybe too much to drink at night or something.
Guys are so unkind to themselves.
Guys are so man, I'm a man.
Because it's just like what that guy was saying, one of the biggest problems is you're going to dismiss it.
Yeah.
But I think that's generally with men. Rob, final word to you.
Oh, I was thinking the final men should with
Yeah.
Darren.
No,
and
we always
Tony,
want to-
actually,
you're
because
here as
actually
well.
It is all about you guys, and
Yeah.
it's been really great
Yeah.
speaking to you. Yeah, I mean, I would just sort of, I guess, almost echo that actually our job as healthcare professionals, very much with prostate cancer, is enabling people to live either with it or having survived it. Now, unfortunately, that's that's not all patients, and there's a lot of variation. But actually, to some extent, knowledge is king, and if we, and sometimes finding out about it is the best starting point. I think nearly always it's the best starting point. And as you say, don't be afraid to ask. Nobody's going to force you into a test. Nobody's going to force you into an operation.
Yeah. Gentlemen, thank you so much.
It's been
I
a
really
pleasure,
appreciate
thank
you coming along today
I've
and
got to say,
giving some
I've
time.
learnt a lot from just listening to Rob
Good.
today.
Right.
And likewise with you guys. Thanks.
Thanks very much.
Right. Thanks very much, guys. I
Okay,
really
thank
appreciate
you.
it.
All right,
Thank
take
you.
care.
As I mentioned before, in 2023, 55,000 men were diagnosed with prostate cancer, yet prostate cancer kills 12,000 men each year. Jez, my partner, was one of the 12,000. Jez was a Dublin-born, self-taught artist and studied the techniques of the Renaissance 15th and 17th century masters. He was at the pinnacle of his immense creative ability, clearly demonstrated by his painting, The Diver. This painting was to be his last completed work, and it is a painting which I am grateful to the Marie Curie Hospice staff for hanging in his room. Jez passed away peacefully at the Marie Curie Hospice in Glasgow on the 28th of November 2023. I will never know if he saw his painting for the last time, but I hope so. When I look at the painting now, I think of Jez and of the fate of us all when the time comes and we hover between life and death. I have retitled the painting Precipice in Jez's memory, and I hope his approval.